Welcome back to the Neurophilia Podcast. As always, I am your host and fourth-year medical student, Nooper Goyle. In today's episode, we will be discussing the fascinating relationship between neurology and psychiatry. Compared to most other organ systems, the brain is uniquely divided into two medical specialties, neurology and psychiatry. Prior to the 20th century, however, these two fields of medicine were often practiced together under the umbrella of neuropsychiatry. Prominent thinkers such as Hippocrates and Charcot believed that psychopathologies arose from the brain and were treated as such. So, what caused the shift in medical practice? Well, the advent of psychoanalysis and neuropathology, coupled with a growing dualism of mind versus body and organic versus functional, led to a massive division between neurology and psychiatry in the West. More recently, however, scientific literature and neurodiagnostic imaging are blurring the lines between these two fields of medicine. An estimated 50% of patients with primary neurologic disease will also experience psychiatric illnesses such as anxiety or depression. This includes conditions such as TBI, neurodegenerative disease, stroke, MS, and epilepsy. In NMDA and autoimmune encephalitis, 40% of patients will initially present with psychiatric symptoms of hallucinations and agitation, and thus a whopping third are first evaluated by a psychiatrist. For a more in-depth review of all studies and statistics mentioned in the episode, please check out our episode's description for more information. In her New York Times best-selling autobiography, Brain on Fire, Susanna Cahalan recounts her battle with NMDA encephalitis. Prior to receiving treatment, she was actually misdiagnosed with psychiatric ailments such as bipolar disorder and schizoaffective disorder. Her story, which I encourage everyone to read or listen to if you haven't already, is a brilliant example of this intimate relationship between neurology and psychiatry. And one of my favorite quotes from her novel is, "The brain is a monstrous, beautiful mess." I want to repeat that quote one more time because I absolutely love it. The brain is a monstrous, beautiful mess. And I bring this quote up and I repeat it because I know it will resonate with both of our guests in very similar as well as different ways. So to help me discuss the beautiful and monstrous relationship between these two fields of medicine, I have with me vascular neurologist and neurophilia co-host, Dr. Blake Buletko, and special guest, Dr. Randon Welton. Dr. Randon Welton is currently the Margaret Clark Morgan Professor and Chair of Psychiatry at the Northeast Ohio Medical University. He is also the president of the American Association of Directors of Psychiatry Residency Training. Before arriving at Neomed, Dr. Welton has had a long career as both a military psychiatrist and psychiatric educator with a focus on psychotherapy and addressing the impact of trauma on mental health. Dr. Randon Welton, welcome to the Neurophilia Podcast. Thank you so much for being here.
Well, thank you so much for inviting me. This is a delight for me. And one of the things that makes it especially important is I was very, very close to becoming a neurologist. It was the fourth year of medical school before I decided which of these two fields, both of which I loved, that I was going to end up going into. And you had talked about the history, and it's a fascinating history about how neurology and psychiatry diverged during the last century. And just a couple of thoughts about that. You know, Freud, the father of psychoanalysis, he was trained as a neurologist. Alzheimer was trained as a psychiatrist. The two fields were very, very close together. But what seemed to happen in the beginning part of the 20th century was the technological limitations of studying brain function. We just couldn't tell what was going on in the brain. Plus the discovery that you could help people with significant anxiety, depression, other kinds of mental illness. You could treat them with psychotherapy and then by psychopharmacology without really understanding what was going on in the brain. That led to that divergence between the two fields. And then they gradually divided by theory, the focus of research, sometimes even things like vocabulary, the interventions we had, and they've grown apart. But the wonderful and exciting thing is that now with advances in kind of neuroscience and imagery and other studies, we're starting to come back together. So it's really exciting for me to be here and talk to you about this interaction between neurology and psychiatry.
Absolutely. Well, I mean, I thought it was so fascinating to sort of hear about your journey to becoming a psychiatrist, and hearing about this inner turmoil between the two fields sort of talks to how interconnected neurology and psychiatry truly are. And so I want to get right into this conversation that we've already begun. But, Dr. Welton, Dr. Buletko, could you sort of talk a little bit about the interactions between your two fields of medicine?
Yeah, and Randy, thanks for being with us. Obviously, Nooper and I are both very excited to have you. And similar to you, I had a lot of uncertainty about where my career was going to take me. And we were just chatting before we started recording about the fact that I was very interested in neurology and psychiatry. And I had a lot of great mentors who were neurologists. I had a lot of great mentors who were psychiatrists. And I really loved the interplay between them. And I looked into and applied to combined neuropsych programs, and we were chatting a little bit about that. And so it's funny that, we are two different specialty physicians, yet we both have a lot of interest in each other. And so I'm looking forward to our conversation and this episode. I would say, Nooper, to your point is how do we interact? How do we, get along? I interact with psychiatry all the time. Psychiatry, psychology, a large portion of my patients, being a predominant stroke neurologist, have some comorbid psychiatric disease. And I think it's under-recognized. I think it's probably undertreated. And this is just what I do day in and day out in my clinic. So I'm on hospital service right now, and I can tell you that every time I'm on hospital service, I'm on general neurology service right now, and a lot of it is a lot of combination between neurology and psychiatry. We consult together on each other's patients. You have to have an understanding of recognizing disease and the comorbid complications that come along with it. And I'm sure we're going to get into it, but there is a whole host of combined diseases that we see both in neurology and psychiatry. And then we also see a lot of manifestations of neurologic disease with psychiatric comorbidities. So probably out of all the specialties, maybe other than medicine, that I interact with, psychiatry is near the top of the list.
Yeah, I was trying, and I don't have any data or numbers to back this up, but I was trying to think of which are the 4 cases or situations where I interact most commonly with neurology. And the 4 I came up with, first one is dementia. Very frequently to have both neurology and psychiatry involved with the same patient with dementia. Consults for functional neurological disorders, what we used to call conversion disorders and so forth. That's a pretty common on the inpatient units and in the hospital. Traumatic brain injury. Again, I came out of a military background, so that was a very common situation where you would have both psychiatry and neurology involved. And then HIV-related changes, perhaps a little less now than in the past because of improvements in treatment. But it wasn't too many years ago where that was a really common kind of situation where psychiatry would be called in or neurology would be called in. Both of us consulted to the infectious disease ward to manage patients. So there is a lot of overlap, and it's an interesting difference in perspective sometimes of how you categorize things, how you describe things, and how you proceed forward.
Yeah, I would say too, another common one that we run into issues with sometimes are the neurodegenerative disorders. And, a lot of the medications that we love for our neurodegenerative patients or our Parkinson's patients may not interact very well with what we're trying to do and manage from a psychiatric comorbidity standpoint. And oftentimes the treatment for both of these 2 things that you're trying to treat well together, they're diametrically opposed treatments, making some of the psychiatric manifestations of neurodegenerative disease worse. And some of the psychiatric medications that we're trying to use to help with symptom management can make the underlying pathology of some of these diseases worse as well. So it's always a fine line that we're kind of balancing between. But I think that it's one that we do pretty well as colleagues. And I have to say that some of my favorite colleagues are some of our psychiatry, folks.
One thing I started, this was at the last place I worked before I came to Northeast Ohio Medical University. Uh, I was running a psychiatry training program, and I worked with the neurology training program, and we started to create combined rounds, which was a fascinating opportunity. One side or the other would present a patient in that kind of gray area between our two specialties, and to hear how the others would proceed, how they would conceptualize this patient, what they would think of doing, what their next step would be, was a fascinating learning experience for their residents and our residents, and was something that our residents just didn't have before. And it was I came up here, and I don't know if it's still continuing, but it was a great opportunity to learn from each other.
Absolutely. Well, I mean, already this conversation is it's just perfect because, the brain, the way that you look at it from neurology and psychiatry is obviously, as Dr. Buletko said, sometimes diametrically opposed. But there's so much overlap between these two fields of medicine. And I wanted to go back to something that Dr. Welton, you mentioned briefly, this idea that there's a lot that you can learn from your neurology cohorts when you have to interact with a lot of these similar patients. And so I'm wondering, from both of your perspectives, what can neurologists learn from psychiatrists in terms of diagnosing and treating patients? And what can psychiatrists learn from neurologists when it comes to patient management?
Well, I will start. One of the most exciting aspects of being a psychiatrist in 2023 is our growing understanding of underlying neuroscience and underlying neurobiology. That we have moved from a simple, lesion focused understanding of how the brain works to a lot more circuit based understanding. And some of the most exciting aspects of what I do and what I talk about are those kind of networks. So the amygdala and the salience network, which is extremely important in post-traumatic stress disorder, which as a military psychiatrist was extremely important to me. The hippocampus and memory and the emotional content of memory, the nucleus accumbens and the ventral tegmental area, and their interactions with addictions of all sorts. That kind of understanding starts to now inform how we treat patients. The circuitry of obsessive compulsive disorder, for example. We're starting to base our treatments a little bit more on what's going on at the brain level rather than just the clinical outcome, which is for decades what we based our treatments on. It's not bad. It was just the state of the science at the time. We gave this medication and this person got better. That's great and that's fantastic. We don't know why, but they got better. Now we're starting to say, well, what is changing that leads to the symptoms that we're seeing? And then how do our treatments change those symptoms? Let's base our treatment on that. And that understanding of the neurobiology, the understanding of neuroscience is something that I think we would lean heavily on our neurologists for.
Yeah, and the other way around, there are a lot of similarities that I think we share. And in one of our other episodes, Nooper, we talked a lot about storytelling. And in order to be a good storyteller, you also have to be a good listener. And we talked about the storytelling of neurology and the listening to the patient's story. And perhaps, for all the neurologists out there, I'm sorry, but perhaps people that do this even better than what we do are our psychiatry colleagues. And who listens to a patient's story better and tells their story than psychiatrists? I can't think of any that do. And so the fact that we approach patients in a similar fashion, the fact that we really dive into who they are as people to understand what their pathology is and what it's meaning to them as people, I think is really, really powerful. And, as much as we've talked about the biology of psychiatry and more and more of neuroanatomy that we're learning and linking with psychiatry, I also really appreciate our psychiatry colleagues coming in with a fresh set of eyes. And if there's a patient that we're having a really, really hard time figuring out, that there's not this great organic underlying diagnostic, etiologic kind of explanation for what's going on, sometimes we scratch our head and say, should we get psychiatry to come by and give us another opinion? And I'll be honest with you, it's very rare that we don't get some valuable information from our psychiatry colleagues. And how powerful is that you can have two sets of people that look at the brain in very different ways, but have enough overlap to where you can really do great things for the patient. And the last thing that I'll mention is, medications have evolved quite a lot, and it's very difficult to keep up with the pharmacology of a lot of the medications that are used by psychiatrists. And so oftentimes I find it very valuable and helpful to get psychiatry's opinion on medication effects and what the best medication treatment options are, considering so many of our neuro patients have psychiatric comorbidities. I find that extremely helpful to really understand the pharmacology of what you're doing and how that's interacting with the brain. Last thing, and you can close this or you can edit this out if you want, Nooper, but I have to lay a shout out because one of the psychiatrists that I was on service with, the other thing that I love about psychiatry is they're observers, just like we are. Sometimes there's a lot of power in just observing what's going on. And we were waiting for an elevator, and it beeped, and I immediately just went to get in and go up. And the psychiatrist I was with said, Blake, just wait. And I said, well, what do you mean wait? The elevator's here. And he said, if an elevator dings once, it's going up. If an elevator dings twice, it's going down. And just something so simple to where he paid enough attention to the elevators. And I said, is this like a hospital thing, or is this like a universal approach to elevators? And he said, you go to different places and you let me know what you find out. And it's universal. And no one has ever said, you don't need to look for the light that goes up or down, just listen to the sound. And I've observed that one beep is up, two beeps is down. So anyway, it's something silly and something small, but it just, again, reinforced the power of observation and really taking your time with recognizing what's going on around you.
I didn't know that. I'm going to have to pay attention to that going forward. That's fantastic.
I don't know how there that are listening, go and do some experiments and let me know if you find any discrepancies with that.
And I don't know how many most exciting aspects I'm allowed to throw in, but I'm going to throw in one more most exciting aspect, which is really our growing awareness of the bidirectional model of brain and behavior relationships. That obviously the brain directs behavior, it experiences the world, it interprets our interactions with the outside world. We've known that for a long time. But what we're starting to recognize more is how psychosocial surroundings, our circumstances, our environment, through epigenetic kind of modification, actually impacts brain functioning and gene expression within the neurons of the brain. So what we have always referred to as biopsychosocial is absolutely real. And it's just another name for epigenesis, and kind of understanding how that affects the functioning of the neurons, how it affects the interactions of the neurons, and how those real world experiences and circumstances get relayed into actual brain functioning is another area where psychiatrists aren't necessarily good at that. We're good at biopsychosocial in general, but understanding the mechanism beneath it is something that we're just starting to learn. And I look forward to learning more from neurologists and other neuroscience, because that's one of the most exciting parts about being a psychiatrist.
Nooper, you're going to have to cut us off because I think we're just going to keep going back and forth about what we love about about the other, about our colleagues and the fact that we're just so, enamored with the brain. And again, it's a big, beautiful mess, right? And we both absolutely love it. And I think that you're seeing a lot of that already.
Yeah, I don't want to have to cut either of you off because I'm in great company here. So I'm having the time of my life. But to sort of shift the gear a little bit, something that I talked a little about in the introduction was sort of how oftentimes neurologic disease can manifest as psychiatric symptoms and vice versa. And both of you have already mentioned this idea that there's a lot of comorbidities between these two organ systems. And so I wanted to bring up this piece that I heard about from a friend and I did some research into. And it was a piece published in the Neurology Journal back in 2016. And it was titled The Terrorist Inside My Husband's Brain. And it's actually written by the wife of the late famous actor Robin Williams, Suzanne Schneider Williams. And, Robin Williams, most people know that he suffered with depression, but it turns out that he also suffered from diffuse Lewy body dementia that wasn't actually confirmed until, postmortem autopsy. And so in this editorial, Susanna writes, a prior history can complicate a diagnosis. And so the question that I have and how it relates to comorbidity comorbidities is, does a prior psychiatric or neurologic history of a patient sort of influence the way that you perceive new complaints?
I can tell one story, and we are going back away. We're going back to my first rotation as a resident, and I'm not even going to tell you how long ago that was, but it's probably before you were born. And it was on an inpatient neurology unit, and they had admitted a patient to the neurology unit. And this again is a long time ago, and she had a historic diagnosis of schizophrenia. And they said, well, the psychiatric unit is full. We need to get her out of the ER. So we're going to place her on the neurology unit until a bed opens up. And they described her as being catatonic and as being uncommunicative. And the folks in the ER just kind of wrote it off as a psychiatric condition. Fortunately, when we got her onto the neurology service, I was a resident, the senior residents and the attending, we quickly recognized, no, there's changes in reflexes, there are changes in strength. This has nothing to do with her psychiatric condition. She had a subdural hematoma that was causing significant impairment in her communication abilities. And we got it, we identified it, we got it managed. But there is that tendency, again, maybe I feel it more as a psychiatrist, that once you get that psychiatric illness label, that people stop taking your symptoms as seriously. And that, you can miss things that way.
I couldn't agree more from our side as well. Functional neurologic disorders, and I'm glad that there's been a lot more recognition that has surrounded people with functional neurological disorders in the last several years. But there's a lot of labeling, there's a lot of stigma that's associated with some of these. And I think that it's easy to write some people off as a neurologist if you don't feel like there's a substantiated organic pathology to what you're trying to see. And now that the field is changing to recognize that maybe we just don't know what that is yet, maybe that there's more to this. And if you reshift your thought, instead of we can't give this person steroids or TPA or IVIG or plasma exchange, but what can we do? There are a lot of things that we can do for patients, and most of these patients do really, really well with the right type of therapy and with encouragement, with rehab, with all the things that we should be focusing on. So there are so many treatment options that are there that can really benefit the patient, but you have to recognize what you're dealing with. And it's not just saying, I don't see anything organically, your brain MRI is normal, goodbye, this is all made up. A lot of patients will tell us, we hear this is all in your head, this is all made up, this is something that you can stop. And we see this a lot with non-epileptic seizures. We see it with functional neurologic disorders. I see this a lot whenever patients present with focal neurosymptoms and we think that someone's having a TIA or a stroke. I mean, we could go through lists and lists and lists of comorbid disease with, dementia, schizophrenia, bipolar, MS. We've talked about a couple, drug abuse, even migraines. I mean, you can really take this to almost every single neurologic disorder that you can think of. CNS lupus now is referred more commonly as neuropsychiatric systemic lupus. So I think that we're getting there. I think that it's a work in progress, but you're right. If you get labeled one way or the other, it's very hard to reshift focus. But I think that that's a reason why we're being more attentive to the comorbid diseases, and also why our psychiatry colleagues ask us to comment on, do you think that there is an alternative organic pathology before we start treating this as a primary psychiatric condition? Let's make sure that we're not missing something else that maybe would lead us down a different path. And I think that that's really powerful.
And I think this occurs in all of medicine, perhaps more strongly in our two career fields, where you define the person by their diagnostic history. A lot of patient-centered approaches to patient care. So, the patient with schizophrenia, rather than calling them just a schizophrenic, that we have, and it's certainly within my field, but we have for a long time defined the individual by the illness that they have. And that's unfair to them, and it's inaccurate, and it's not how you're going to help them. So I think we struggle with that in all of medicine, and in my field, certainly, perhaps in neurology as well. But it's an area where we need to grow and do better.
That's a great point. I love that point.
Well, thank you both for commenting on this. And Dr. Welton, hearing about your own personal example of, this sort of anchoring bias that occurs in medicine especially when it relates to psychiatry, because there's such a stigma, associated with psychiatric conditions. It's important to keep an open mind and obviously have a very broad differential and consider the fact that there might be alternative processes at play. So thank you both for indulging me in that conversation. And to shift gears, because both of you are so heavily involved with medical education that I would feel like we were missing out if we weren't sort of heading in that direction. But something that I talked about in the introduction for this episode was sort of the history of neuropsychiatry and how the two fields of neurology and psychiatry were united at one point in time in history and sort of have divided over the last sort of century or two. And so more recently, however, there has been this international effort to better define and integrate the discipline of neuropsychiatry into neurology and psychiatry residency training. And while there are some scholars that argue that this is a great idea and that better unity will allow for these two fields of medicine to provide more holistic patient care and maybe bring more medical students into the professions of neurology and psychiatry, others argue that the two fields are so diametrically opposed and there's such different discourse that occurs that it's very difficult to bring these two fields of medicine together. And so I'm curious, from both of your experiences with medical education, with dealing with residents, can you comment on the level of integration and interdisciplinary training that is available at the residency level?
I will jump in with psychiatry. Now, one of the things that guides this is the fact that our certification boards is the American Board of Psychiatry and Neurology. So it's the same board that certifies us both. And so there is overlap. So I think it's roughly a third. So on the psychiatry, board certification, roughly a third of the questions are neurology. And I believe the opposite is true for neurology. So there is a need to train. I know for psychiatry residency training, the requirement is 2 months of neurology. That at some point, and one of the months has to be in the first year and all that you have to have a 2-month dedicated rotation on neurology where you can identify those in neurological crises, for example, stroke, where you can differentiate conditions that are typically considered neurological from conditions that are better explained as manifestations of psychiatry, and to understand when and how to consult neurology intelligently and in a useful fashion. So for us, there's a mandatory 2 months that all of psychiatry residents spend on neurology. There are, I looked it up, there are 4 kind of combined neurology psychiatry programs, but they're very small. I think they have a total of 4 spots between them, and that's in the entire country. So it's a very, very small area right now where you get that true combination. But as you pointed out, one that might be growing as we understand more of the neuroscience behind psychiatry and more of the psychiatric components of neurologic disorder. But I'm very interested from a neurology training point of view. How would you see that?
Yeah, you stole a lot of my points, and I'm not surprised because we're pretty much on the same page with a lot. Yeah, I mean, the shared board since 35, I think speaks volumes. I was looking up in anticipation of this podcast to kind of go and see what the breakdown of our board exam was for last year and this coming year. And, it's 5 to 7% of just primary psychiatric disorders. But then if you search for psychiatry within the outline of what is going to be tested, you see psychiatric manifestation of XYZ, almost everything else that's tested on the boards, there's some manifestation. So I think that you're, accurate in saying, the percentages that are flipped. And that's historically what we've been taught is about 30% psychiatry and the rest neurology. And so, from a residency standpoint, right now, the current, ACGME requirements are 1 month of psychiatry, and that's dedicated psychiatry. So we feel that it's really important for our residents to get this very early on in their training. And so we have prioritized doing this during their first year of training so that they can then use the information that they have moving forward. But this is just 1 month, or to your point, 2 months of dedicated time. The time that you're getting even taking care of primary psychiatric patients or primary neurology patients, it gives you so much more exposure to everything that we've been talking about. And so it's an ever I guess, an ever-long learning from, as a neurologist, what exists from a psychiatric world standpoint, and how can I best serve my patients with these comorbid conditions. Again, to your point about the combined programs, the advice that I got whenever I was really struggling between going back and forth between neurology and psychiatry is, at the end of the day, someone told me, you have to primarily be a neurologist or a psychiatrist. And I know we've talked a lot about bringing these two fields together, but it resonated with me because both of these fields, and I think people that go into these fields are really excited because the brain is still a black box. And we say there's going to be so much yet to find out about the brain and about the interaction between the brain and the mind. That's a field that I want to go into because it is just going to be booming in research, and we're going to find out so many things. The problem with that is if you are dual boarded in neurology and psychiatry and you are actively trying to practice both, that is a lot of information to try to digest, to try to keep up with. I was having a chat with our residents yesterday and today, and there's over 30 subspecialties of neurology right now. And so even trying to stay up to date with everything that there is as a general neurologist is just so overwhelming that trying to do that in kind of combination with keeping up with psychiatric literature, I couldn't even imagine trying to do both. Where I think it's really helpful is as a subspecialist neurologist, how can I understand my subset of patients as well as what I can? And that's not just from a neuro standpoint, that's from a comorbid standpoint, from a cardiology standpoint, an endocrinology standpoint, and definitely a psychiatry standpoint. I still feel very strongly that we probably under-recognize a lot of our patients with some underlying psychiatric comorbidity that either we don't know how to recognize, we are scared to recognize it because it takes more time, or we don't know how to treat it after we've been able to identify that it's there. And I think as neurologists, if we can really pay attention to what is our subset of patients that we're dealing with most frequently, and can we try to be an expert in that part of what we're doing from a psychiatric standpoint too, I think that would be really good for patients.
Do you think that 1 month of psychiatry exposure and residency for neurology and 2 months for psychiatry and neurology training is enough at the resident level?
I would say clearly it's not enough, but the problem is without continuing to extend residency longer, what are you going to cut out for it? So psychiatry residency, counting your first internship year, is 48 months. So, 2 of those 48 months are in neurology. 4 of those are in primary care, 12 of those are in outpatient psychiatry. It's hard to find. No, we do have some elective time that people can choose to go back and do neurology. The problem is just finding, what do we cut out in order to expand neurology without extending the residency even further? And so far, we've just been unable to do that. So I think neurology is probably in a very similar vein. It recognizes the importance of it, but it's just, there's so much to learn in neurology. You don't want to cut anything, there's no fat to trim off of that.
Yeah, I agree wholeheartedly. I think that it also emphasizes the fact that you should learn from your consultants. If you're seeing a patient and your consultant comes and makes recommendations, don't just look at a screen and put an order in or say, okay, this is what we're doing. Try to understand why and the rationale behind it. And the same as if you refer one of your outpatients to a psychiatrist. Really follow up on what happened, what medications did they choose, what did they identify, what did they pick up on that I missed, because that will happen. And then have a conversation with the patient the next time they come in to understand it a little bit better. I think as long as you're learning in that way, 1 month, I'm glad that there's some mandate, but no, I agree. It's not enough, but you can make it enough if you're really trying to pay attention to every, consultant that comes by and sees your patients with you.
And I think that's an excellent idea. We too often find ourselves in self-made silos where, I have a patient who has a neurologic disorder, so I'm tempted to just okay, I will send them to the neurologist. The neurologist will take care of the neurology stuff, and I will just take care of my area. And that's not really doing the best we can for that patient. We really need to understand what that other provider is seeing, what they're thinking, what they're doing, why they're doing that. We need to take time to get that. So and continue to grow in our own professional abilities. No, I think that's an excellent point.
Absolutely. It's that difference between active and passive education and knowledge. You know, with residency, there's always opportunities to learn even beyond the already constructed way. So thank you, Dr. Buletko, for that perspective. And you know, Dr. Welton, the purpose of this first season of Neurophilia is sort of to address neurophobia, which is the fear of clinical neurology amongst medical students and young doctors. And so I'm curious, from your perspective, have you ever experienced neurophobia?
I honestly laughed when you used that term because I had never heard it. But as soon as I read what it was, I said, oh, I've seen it. I just have never heard that term before. I thought that was really funny. And certainly I can only speak to psychiatry, but and it's not so much the specialty of neurology as it is an overarching fear of neuroscience, which is perhaps best embodied by neurology. And this, I looked up a quote. This is from 2020. So 3 years ago, in the British Journal of Psychiatry, so one of the most prestigious psychiatric journals in the entire world, and this was an opinion piece, so it's not science-based, but this is the quote: "Unfortunately, it is still not possible to cite a single neuroscience or genetic finding that has been of use to the practicing psychiatrist in managing serious mental illness." So there's this idea that there's all of that information out there. There's all those thousands and thousands of studies of neuroscience, and none of it impacts what we do. That's the belief that's out there. And it's just so intimidating to open up neuroscience journals and to see those words. And we don't really remember the neuroanatomy that much because it's been a while. And to think that, well, if I take the time to learn it, it's not going to really impact anything I do with my patients anyway. So I think that's, at least from psychiatry, I think that's historically where it's come from, what that fear is. And it's something that we can start to counteract by pointing out what the mechanisms are, why our treatments do work. Now, we don't understand them all, but we're starting to get an understanding. Again, I was a military psychiatrist for a long time, so I spent a lot of time with patients with post-traumatic stress disorder. And it's one of the conditions where we have a really nice, clear line between what happens to the brain after trauma, how the functioning of the brain alters after traumatic events, how our treatments counteract that, and how that leads to improvement. And I think over time, we'll start to be able to do that, draw that connection with more and more psychiatric conditions. And when we do that, then neurology and neuroscience in general becomes a whole lot less intimidating and a whole lot less distant. Right now, for a lot of clinical psychiatrists, it just seems very far removed from what they actually do on a day-to-day basis. And that's something through training and education that we can change.
I was curious, Randy, you have a lot of insight, and we touched briefly on your early interest in neurology. What do you love most about neurology? What gets you excited about neurology, if you think about it? I guess, or the field in general. What do you hear from your colleagues about why people love neurology and the interplay between the two of them?
Yeah, and I've kind of hinted at it, and it's that connection between what we experience and what's lying underneath it, how the brain is actually changing, how the brain changes with interaction. You had mentioned in your very kind introduction that I am someone who talks a lot about psychotherapy, and I really value the importance of psychotherapy. And psychotherapy doesn't work magically. Psychotherapy works through changing brain function. And that's the part of psychiatry that I find to be really fascinating. How do I, by sitting down and the two of us talking over an extended period of time on multiple occasions, how do I actually change your brain's functioning so that you start feeling better? In post-traumatic stress disorder, why do the medications I use help? So I'm using, a serotonin reuptake inhibitor for PTSD. Why does that help? It's not like you have a deficiency of antidepressants. That's not the cause of your condition. but what is it changing and how that neuron functions? How is it changing the interactions between the neurons that actually helps you to feel better? So for me, that's the part that's really interesting. How do those changes in the brain functioning, changes in the brain interaction among the neurons, how does that result in changes in behavior, changes in emotions, changes in reaction, changes in the use of language? And that's the part for me that's really fascinating, actually, both about neurology and psychiatry.
Beautifully said, Dr. Welton. Just beautifully said. Doctors Blake Buletko and Dr. Randon Welton, thank you so much for your time. And it was just such an honor and privilege to hear your perspective on this beautiful relationship between neurology and psychiatry. And, before we conclude, I want to ask you, Dr. Welton, about your no-brainers. And these are going to be 5 rapid-fire questions that you can respond to with 1 word or 1 sentence maximum.
Oh, I don't know if I can respond to anything with, okay, I will try my best.
Well, we have phenomenal editing skills at our disposal. You know,
can edit it down.
Yes, if we need to, but I have full faith.
It might be a very, very long sentence with a lot of clauses in there.
That's okay. You take whatever you need to get these questions done.
Okay.
Are you ready to go?
Yes.
What was your favorite part of this conversation?
The mutual excitement. My excitement about neurology, Blake's excitement about psychiatry.
Love it. What do you hope changes with the next generation of psychiatrists?
Much of what we were just talking about, that increased excitement about the neuroscience that underlies what we do.
What is your solution for burnout in medicine?
Okay, this one is going to be a tough one because this is something I tend to talk about, and I've done a lot of presentations on this. So I will do it as quickly as I can.
Take your time.
There's the realization that no single solution works well for everyone, and actually doesn't even work well for the one person in multiple situations. So there's really 4 different areas, and depending on who you are and what you're going through, it might be a personal intervention. That's the famous yoga, yoga and exercise and getting hobbies and stuff. It can be a workplace intervention. What are the pebbles in your shoe? What are the things that just annoy you about where you work? Sometimes it's a very simple change. Sometimes that's what needs to happen. Sometimes it needs to be organizational changes, expectations, support staff, workflow. Sometimes it's workplace. But one of the interesting ones is reminding ourselves of the meaning, value, and significance of our work. No one gets into medicine so that they can sit at a computer and click electronic medical record boxes, right? We got into medicine because we want to help people. We want to interact with people. We want to learn about our patients and help our patients. And sometimes the best key to improving resilience or diminishing burnout is to remind yourself why you got in medicine in the first place. What was valuable about it when you started? What makes it exciting now? That's as quick as I could do it. Sorry.
Wow. No, I absolutely love it. What is your favorite book?
A tough one. Old Man and the Sea. The depiction of a struggle against overwhelming odds and how little anyone understands about the struggles that others are experiencing.
And the last question I have for you, Dr. Welton, what are you most proud of?
Okay, I pretty much have to say children, just in case they listen to this. So my children, in case you are listening, if my children aren't listening, then I have just returned from the annual meeting of psychiatry residency training directors. And what I'm most proud of is the number of my former residents who are now clinician educators, who are now involved in residency training, some of them leading residency training programs, and seeing some of that passion that I think I have about the field being passed on to them and to the residents that they train.
Absolutely. Well, Dr. Welton, your passion for psychiatry and medicine and medical education, it's palpable. I can feel it, through the screen. So thank you so much for your time. I really
thank you. Yeah, thank you for inviting me. It was great to meet you.
Randy, I feel like we're cut from the same cloth. I was looking down and she started doing no-brainers, and I was like, wait a minute, like our time's not done yet. And then I realized that we've just chatted for nearly an hour, and it just flew right by. So I have to thank you again as well from my standpoint. And I do feel like we share a lot of the same passion and energy for what we do, and that's really, really special. And I think it just goes to show how complementary psychiatry and neurology are. And I thank you for everything that you've done and everything that you do, and especially in the world of medical education. So thank you. And I'm sorry that our time is already up.
I am too. Very, very quickly. Thank you very much for organizing this. This was great.
Absolutely.